Hey guys, just wait a minute or two for more people to arrive here and then we'll continue on with our talk about female or fetal development. Just going to just see if there's a couple more things I can open here. Alrighty. Things working very slowly. All right. Sorry, I'm just opening a couple of videos just to get ourselves apprised with that. And we'll start in 1 minute here. Sorry, my PowerPoint is doing what I want to. Get that. And this one. I think we are. Pregnancy and development. So here we are. I hope everyone's doing okay. Our numbers have gone down significantly. 6 people. I remember the days of 22. That's all right. The goal is to be done this booklet by the end of class on Friday. So we're going to get through some stuff today. I did give you the worksheet that was promised earlier today. That is due Sunday at midnight. So that gives me time to go through the rest of the parts that are in that worksheet. So that's for you guys to do. And remember, I will pass that back to you guys on Monday, and then you have your big unit exam, and then we're done. So just be ready and expectant for that. Also, if you have not written your quiz, your female reproduction quiz, it is posted and ready to go. So make sure you get on that. It closes today at midnight. All right, we are going to, without further ado, start talking about placentas. So let's share this. I'm just going to move that up here. Oops, too far. For whatever reason, my PowerPoint seems to be very sluggish. Okay, we talked about those. There's our hands up. Okay, so last class we talked about basically the different stages. We want to make sure that we're understanding those different stages of development and when they happen in the female's body, right? So we're starting with ovulation. So remember, ovulation, that secondary is making its way into right from you. One thing I noticed when I was in my female reproduction sheets, ovulation is just the leading the cytochrome from the ovary. That's all it is, right? And then it should get to the fallopian tube. When it gets to the fallopian tube, that's where fertilization may happen. If it does happen, then that kicks off meiosis 2 to finish. So remember, meiosis is affected by having tubal ligation, because the tubal ligation prevents the sperm from coming, which means it can't fertilize that egg, which means meiosis 2 doesn't happen, right? So that has an impact, because meiosis 2, of course, is the second part of oogenesis. Okay. So now we have a fertilized egg, divides through the process called cleavage, where the cells are getting smaller and smaller. We get towards the uterus, and now we have this full ball of cells called the morula. The morula differentiates to become the blastocyst with the inner cell mass and then that outer structure. The outer structure becomes the chorion. The chorion pushes into the wall of the endometrium inside the uterus to be embedded, so it kind of anchors in there. Okay, and then it releases the hormone HCG. So we want to know those stages, and then about 2 weeks after conception, this differentiation occurs called gastrulation, where the germ layers are formed. So the ectoderm, mesoderm, and endoderm, right? And you need to know basically what each of those levels or layers is going to differentiate into. So when we talk about the ectoderm, we're looking at nervous system and skin. When we talk about the mesoderm, middle of the body, right? So we're looking at circulatory system, skeletal system, muscular system, and reproductive system, okay? And then we go into the endoderm, sort of the inside. So we're looking at the inner lining of the digestive system and the respiratory system, as well as our endocrine system, okay? So we want to make sure we're understanding that. And then through that process of gastrulation, after that, that's where we start to see a real expansion in those extraembryonic membranes, right? So the chorionic villi, we want to know its function. The amnion eventually circumvents the embryo and forms the amniotic sac. The allantois, so remember the allantois is like a side pouch off of the yolk sac, and that's going to develop into parts of baby's bladder and digestive system. And then we have the yolk sac, which is not for nutrients, right? The yolk sac is basically vestigial, but not completely, because it does get incorporated into parts of the baby's germ-forming cells and blood cells, okay? All right, so we want to keep apprised of those types of things, and then we go from those structures, right? We started talking about, I think, the placenta a little bit. Did we? Don't remember. We will get to it. Okay, so I'm just going to show you a little quick video here, and this is just on the extraembryonic membranes. So let's just watch that. It's here. And, oh, sorry, we'll go back to sound. And
the embryo becomes implanted in the uterine wall, where it produces the fetal membranes. These protect the embryo from water loss and mechanical damage as it grows and develops in the uterus. The embryo is surrounded by the amnion and chorion. The amnion is filled with amniotic fluid and directly encloses the embryo. This protects the embryo from damage and water loss. The chorion develops characteristic chorionic villi, which fuse with the uterine wall to form the placenta.
So we want to remember that the placenta is a joint structure, right? So when I think about the placenta, let's just use this. When I think of this whole big structure here, that's the placenta, right? So these are the chorionic villi, and again, we want to remember that's just fetal cells, and these are little fetal blood vessels, okay? So all of this is fetal cell. The only time we get to maternal cell is the blood of the mom, and then the endometrium here.
The function of the placenta is to obtain oxygen and nutrients from the mother and to eliminate waste metabolites from the embryo. The developing embryo is connected to the placenta by means of the umbilical cord, which contains blood vessels. The third fetal membrane is the allantois. This is an outgrowth of the embryonic alimentary canal and is poorly developed in human beings. The allantois fuses with the chorion, and its blood vessels help to form the umbilical arteries and vein.
Okay, that's enough of that. So we'll just cancel this and go back to this. All right. So the placenta. So this is what a placenta looks like, and we can see the umbilical cord attached. So we want to remember the placenta is what baby is joined to. So the other side of the umbilical cord is attached to the navel of baby. So placenta is formed by the chorionic villi. So remember, the chorionic villi, the finger-like projections, that's embryonic DNA. And the endometrium, which is maternal DNA, okay? So it's a combo organ of both of those cell types. So the embryonic blood vessels are bathed in pools of maternal blood. So the blood vessels within the chorionic villi are within the, pushed into maternal blood, okay? But fetal and maternal blood do not mix. So when we think about the movement of nutrients and the movement of waste products, that's just through diffusion. So it's going to diffuse from the maternal blood into the chorionic villi where the blood vessels are, so into the fetal blood vessels, and the waste is going to diffuse out. The blood doesn't mix, so mom's blood and baby's blood aren't flowing together, okay? So the site of material exchange, that's the placenta, through diffusion. So that's really important to understand between mom and developing embryo or fetus. Okay, embryo again up till about week 9 after conception, and then it becomes the fetus. Okay. All right. So if we just take a look at this image here, fetal blood vessels in the chorionic villi. So I just want to emphasize that, right? All of these structures here are fetal DNA. So that's fetal DNA with the fetal blood vessels, fetal DNA. And then this, that's the pools of maternal blood. And then that's mom's blood vessels in the endometrium. So that's maternal DNA, that's fetal DNA. This is fetal DNA, okay? So again, we want to look at where that exchange is happening, right? The waste products, carbon dioxide, urea, so anything that's extra is going to go to mom. And then the nutrients, right? The oxygen, antibodies, vitamins, all that stuff is going to diffuse from mom into the chorionic villi where the blood vessels are, and then up through the umbilical cord. Okay. All right. So just understanding that that nutrients or that exchange does not involve the blood mixing together. Okay. Now the next thing I have to show you here is the umbilical cord. So here we see the umbilical cord. There we are. So that is all fetal. So everything in the umbilical cord is fetal DNA. The inside is filled with fetal blood vessels. So connects the embryo by the navel to the placenta. Contains fetal blood vessels. There's no maternal cells here, right? The whole entire umbilical cord is all baby cells that all came from that original zygote. The thing to remember with this point here is that nutrient and waste exchange doesn't happen here. The waste exchange happens at the placenta. Then whatever's happened is carried through the umbilical cord, but there's no exchange that happens in the umbilical cord. Okay, and then just one more image here. Just going to move you down here so we can see. So we're looking at about week 10 in this image. And so what do we see here? Actually, I'm going to just use the spotlight instead. So what we see here, so there's our embryo. Well, it would now be called a fetus, developing. Okay. If I look at these structures, there's the uterus. So that's the muscular layer of the uterus, the myometrium. Okay. We see the inner layer of the uterus. And here, all those little projections, that's chorionic villi. So that's embedded within the endometrial lining. So we see this embedding. So that and this sort of purpley color are comboed together to make the placenta. There's the umbilical cord and the yolk sac, amniotic fluid, amnion, and then the chorion is on the outside of that, forming the villi. Okay. And then if we take this image here, that's blown up so we can see a better view of it. So we can see what's going on here. Here's where the exchange is. So if I look, there's mom's blood, right? Here's the pools of blood here. The diffusion will happen through the chorionic villi into the fetal blood. So let's say there's oxygen here. So oxygen will diffuse through. And then, okay, oxygen will go through the blood vessels, right? But now it's just, there's no exchange happening here. The exchange is happening in the placenta. And now it's traveling through the umbilical cord, and then from the umbilical cord, it'll get to the cells of the fetus, okay? So highlights that we want to get from this is that there's no exchange of blood, first of all. Mom and baby's blood is separate, so nutrients and waste move only through diffusion, okay? And the other thing to understand is that exchange of nutrients and waste happens at the placenta, not at the umbilical cord. This is all fetal DNA. Okay. All right, teratogens. So teratogens are any agent that can disrupt development of an embryo or fetus. Okay, so anything that we can, as a pregnant woman, you can be exposed to, ingest, etc., can cause damage. That can cause damage to that developing embryo or fetus is a teratogen. Oh yeah. So teratogens can include drugs, alcohol, some pathogens. It can be drugs that are prescription drugs or drugs that are non-prescription drugs, so some illicit drugs. So alcohol, for example, so we talk about that. There's no safe time to really drink alcohol, but the biggest effect most of these teratogens have on that developing embryo is it within that first trimester. And we'll see why after we go through things a little bit more, why that's such a critical time, because most things start developing at that point. Okay, so if someone's drinking alcohol within that first month of being pregnant, alcohol seems to have an impact on the ectoderm where it's going to start affecting the development of the brain. And children whose mothers have exposed them when they're pregnant to alcohol can suffer from a condition called fetal alcohol spectrum disorder. And that is called that because there's a whole spectrum. It can be extremely serious, where the individual can't really learn very much at all. They have very, very decreased cognitive abilities and have very distinct physical features, to the other side of the spectrum where there's still some challenges, but it's not as bad as this side. Some of the impacts, so I taught a child once who had fetal alcohol spectrum disorder, and he, FASD, I can't remember. Anyway, he hated his birth mother. He lived with two very awesome foster parents, but he knew that she drank when she was pregnant with him, and that's why his inability to learn as easily was because of that. And he would get very frustrated as a result of it, because often people who have fetal alcohol syndrome, their brains can't hold a huge amount of information, and ideas of consequences are very difficult. So you make a mistake, you get punished. Most people learn, don't do that again or I'll get punished. Someone with fetal alcohol syndrome may continue to do that because they're not making the connection between the punishment and what they did. Okay. Drugs, cocaine, there's situations of babies whose moms used cocaine when they were pregnant, who were born addicted to cocaine and actually have to be weaned off cocaine because the withdrawal is so severe that they could die, so they get cocaine when they're born in reducing amounts. Cigarettes can cause a baby to have some learning challenges and sometimes a low birth rate. Lead and mercury can have their neurotoxins, so they can affect the development of the brain. German measles, also known as rubella. So most people get that rubella shot when they are 1, and I think they get it again when they're 5. This one here, this can lead to damage in the ear, so they can suffer from being deaf, or they could just die when mom's pregnant with them if they're exposed. And then other pathogens. There are occasions where the herpes virus can actually make it through into affecting baby through the placenta. Okay, so there's lots of examples. So in order for these to cause damage, they diffuse from the maternal blood to the fetus, and then they go to the fetus and they can cause permanent damage, and that's why they're called teratogens. Okay. All right. The placenta also has another function. So besides that exchange of waste and nutrients, it's responsible for producing a couple of hormones called estrogen and progesterone, which we've heard of before, after 3 to 4 months of pregnancy. So remember I talked about how HCG takes over maintaining the corpus luteum? So high levels of estrogen and progesterone at the end of the cycle shut off LH. LH maintains the corpus luteum, so it disintegrates, and we don't have estrogen and progesterone anymore, so we shed our endometrial lining. But when a woman's pregnant, that blastocyst, the chorion, is releasing HCG, which is maintaining the corpus luteum. So HCG levels stay high, highest point around week 8, and then they start to decline right into the second trimester. So when we look at this chart, what we see is that first peak, or this HCG. So if I look at what's going on in the first trimester, which is the first third of the pregnancy, we see that HCG here, it's being produced by the blastocyst, so that's the chorion layer, right? And then we see estrogen and progesterone, they're being produced by the ovary, specifically the corpus luteum, okay? Well, then HCG levels start to decline, and here we see that the placenta is starting to take over the production of estrogen and progesterone. So as HCG is going down, there's very little estrogen and progesterone being produced by the ovaries, the majority is being produced by the placenta. So let's say that we have a woman who is a surrogate, okay? So she didn't ovulate, and if she didn't ovulate, then that means she doesn't have a corpus luteum. So if she doesn't have a corpus luteum, estrogen and progesterone stay low. So in order for her to, her body to implant that blastocyst as a surrogate, she would have to be taking supplemental estrogen and progesterone to thicken up that endometrial lining, okay? But once the placenta takes over the production of estrogen and progesterone, she doesn't have to take it anymore, okay? Because now the placenta is doing the job, and the placenta now, we see these increasing levels of estrogen and progesterone, and what we see is the placenta has completely taken it over here, and we see very little HCG is being secreted at this point, okay? So at this point, about 3 to 4 months after conception, the ovaries aren't being used at all to support the pregnancy anymore, okay? Because progesterone and estrogen are now being produced by the placenta, okay? So we'll see HCG levels start to decrease at that point. All right. So we're just going to run through some of the major events that happen during the pregnancy. So the first trimester is from conception to the 3rd month of pregnancy. This is usually the time where women start to feel morning sickness. So it's usually just that first trimester, although for me, I almost threw up the day my daughter was born. So it really does vary depending on the woman. I had terrible morning sickness for all of my pregnancies, except my youngest. I felt really great after 6 months of pregnancy. So anyway, conception to the end of the 3rd month. So we're looking at a little embryo the size of a centimeter, okay? So this is what our little embryo looks like at the end of the 1st month. So it looks like most other embryos. You wouldn't be able to look at that and just say, okay, well, that's a human. Central nervous system is developing at this point. So there is a little primitive brain in there. 4-chambered heart. So the heart kind of starts as a tube and then it kind of twists around itself to give us the 4 chambers. Circulatory system is functional. At week 3, so we're looking at the size of a grain of rice, a little teeny tiny heart starts beating, okay? Limb buds, or sorry, eyes and backbones, little eye spots are forming. We see the little backbone here, so we see the vertebrae. Everything is made out of cartilage at this point, so there's no bone yet. Limb buds, so we see little buds. So there's no arms and legs, we just have little offshoots where they're gonna form, okay? And then here's mom. So little teeny tiny embryo. Mom doesn't at all notice that she's pregnant, except her breast may have enlarged and she may feel sick. Okay. Oh, come on. Why is this responding? There we go. 2nd trimester. So the end of the 2nd month of the 1st trimester. So baby could be as big as 3 centimeters. So we're looking at just a bit over an inch. External body parts, they're starting, so we see little paddles where the arms and legs are. So there's no, where the hands and feet are, there's no distinct fingers. They're kind of all together. Spine is visible, internal organs are functioning, and by week 7, baby's either a male or a female. Well, will look like either a male or a female phenotypically, okay? So starting to grow, but really mom isn't any bigger at this point. All right, first trimester, so there's a little model of what a first trimester, at the end of first trimester would look like. By week 9, embryo is referred to as a fetus. Gonads are distinct, so male or female. Eyebrows and eyelashes are forming here, and a suckling reflex. So suckling reflex is really important because that's how baby is going to be nourished, so that suckling reflex is practicing for that nourishment, okay? All right, so we see a little bit of the suckling reflex. Mom doesn't show usually by the end of the first trimester, okay? And we see baby looks fairly skinny and a big giant head, right? Heads are really, really big. Okay, the second trimester. So the second trimester, beginning of the 4th month to the end of the 6th month. So halfway through the second trimester, sensory organs are developing. Mom starts to feel baby moving around, and baby can even hiccup. So there's this little hiccup which feels like little rhythmic movements, and you're sort of wondering what this weird rhythmic movement is. Hiccuping is actually a way for the fetus to practice breathing movements. Baby can start sucking their thumb. And I had an ultrasound at this time with my first son, and you could see him sucking his thumb. Fetal heartbeat is detected. You can actually detect a fetal heartbeat through an ultrasound at 6 weeks after conception. But at this point, they're detecting it. They have this little Doppler device that they put on you in the doctor's office, and they can detect, and it's very fast. It's like double or more mom's heart rate. Sex is distinguishable through an ultrasound. Skin is very transparent at this stage. Okay. So at this point, mom is starting to show, and you can feel baby. And I remember with my youngest boy, I could feel him moving a lot, and I looked down and you could see his hand just go right across my abdomen. It was kind of weird. So we see baby's pretty skinny, hasn't put on any fat, but lots of growth is happening. By the end of the second trimester, so baby is about 30 centimeters in length, so 10, 20, 30, so about this long, okay? Opens eyes, so opens and shuts eyes. Some babies will respond if you shine a flashlight on your abdomen. Sleeps and wakes. Usually their sleep-wake cycle is different than mom's sleep-wake cycle. So you may not notice the baby's moved, and it makes mom feel better when baby's moving because you know baby's thriving if they're moving. So what was recommended to me is you just lay down quietly and drink a glass of ice water, and then baby will make a little jump, and then you know that they're okay. Being born at the end of the second trimester, there is a small chance of survival, 10 to 20%. Lots of kids that are born at this point will suffer some kind of delay as a result of that. Okay. So here we see baby. Okay, so this is the end of the third trimester. So mom's getting bigger. If you look at belly button of mom, becomes an outie. That always happens. Okay. All right, beginning of 7th month and end of 9th month is a third trimester. So mom just starts getting bigger and bigger and bigger. So here we see baby all snug up inside the uterus. Fat deposits are forming. So this is where baby starts to gain quite a bit of weight. Body hair is lost. By the end of the 8th month, usually baby's head is started in a downward. So babies tend to be born head first. If they're not, they're referred to as breech babies. So my brother and I were both breech babies. We were born bum first. Period of rapid growth, lots of gain in their mass. So they're gaining a lot of fat. And then month 9, growth stops about a week before, and then the movement downward. Okay. So that's a quick rundown of pregnancy. So we're just going to watch a little video, and this sort of highlights what's going on with teratogens, because when we look at this, and again, this is talking about 38 weeks, which means we're looking at the point of ovulation to the point of delivery. So what you really want to notice when you're looking at this chart is where this major development happens in these different body parts. So for example, If a baby is exposed to a teratogen and they're exposed to the teratogen within the first trimester, well, look at when all that central nervous system development happens in the first trimester. Heart development, first trimester. Upper and lower limbs, first trimester. Eyes, right? So we see the majority of this development is in the first trimester, which means exposure to teratogens. The biggest impact typically is in the first trimester, okay? I just want to talk about upper and lower limbs. So in the 50s, they developed a drug called thalidomide, and it was a drug to help sleep, but it was also used to help women deal with morning sickness. It was released in Germany. And then they noticed this rash of babies being born with deformed limbs, so missing limbs or missing an arm, but having a hand coming from the shoulder, or same thing with the legs. This happened in Canada and in some parts of Europe. It was never actually approved, this drug, in the United States. And what we can see now, sort of looking back, is it obviously affected the development of the limbs, right? So this is when the woman would have been taking it in the first trimester, right? And it affected the development here, which would likely have been the mesoderm, because we're looking at skeleton and muscle formation, okay? So we'll just watch this video. It's about 4 minutes long, but it does talk a bit about teratogens here. Oops.
In a termination of the pregnancy, most often unnoticed, is important. The fertilized egg is not very susceptible to toxic agents. Any trauma at this stage will result in a termination of the pregnancy, most often unnoticed by the mother. Once the embryo attaches to the uterus wall, it will begin its growth in earnest. The cells are still not susceptible to nutritional deficiencies or other dangers from the health and lifestyle choices of the mother. The embryo continues to be susceptible to radiation-induced birth defects. These include cataracts, reduced growth, skeletal defects, microphthalmia, microcephaly, and mental retardation. At 3 weeks, the embryo begins to form the rudimentary organs of the fetus. The embryo is now sensitive to nutritional inadequacies. At this stage, early alcohol exposure can lead to non-viability of the fetus and spontaneous abortion, or fetal alcohol syndrome in the resulting newborn. Other risks are presented by high intakes of vitamin A, medications and prohibited drugs, and trauma. The development of the central nervous system continues for 16 weeks, so the central nervous system is at high risk throughout that period. At 4 to 5 weeks, the central nervous system, heart, limbs, eyes, and ears are all developing and readily affected by inadequate nutritional status. For the heart and limbs, risks diminish after 6 weeks. For eyes and ears, the risks continue for 8 and 9 weeks longer. After 9 weeks, some of these risks diminish. By 6 weeks, the heart is beating, the eyes and limb buds are present. This period shows high risk for major structural abnormalities to the central nervous system, eyes, ears, palate, and teeth, and moderate risk to the heart and limbs. The first trimester is the period when the fetus is most susceptible. The high risk to the palate appears to be limited from 6 to 9 weeks, while risk to the teeth and genitalia continue right through to term. At 8 weeks, the fetus is about 1 inch long. Note the lengthening of the limbs. The risks at this stage are physiological defects and minor structural abnormalities. In the second trimester, undernutrition has a greater effect on the mother than on the fetus. However, hereditary diseases and prescription and recreational drugs are still a danger. At 16 weeks, the fetus is 6 inches long. Physiological defects and minor structural abnormalities are still the major forms of risk, with moderate risk to the central nervous system, eyes, teeth, and external genitalia. 26 weeks marks the end of the second trimester. During the third trimester, the fetus will gain the most weight, up to 5 or more pounds, and increase in size. A major risk during this time is premature delivery. Preterm infants have a good chance of survival if properly cared for. If undernutrition has happened, then the chance of the infant's survival goes down proportionally to the extent of undernutrition. At 38 weeks, the fetus is near birth, weighs 7 to 9 pounds, and is about 20 inches long. Two criteria for a successful pregnancy are 1, a gestation period of longer than 37 weeks, 2, a birth weight of more than 5.5 pounds. It's likely as well. Sound nutrition during pregnancy is insurance of the key.
All right. So it just gives you a little sense, because women, because we're looking at that first trimester as being really critical, that's also the point where a woman might not know she's pregnant and therefore engage in activities that are a little bit more high risk, like maybe drinking alcohol without knowing that she's pregnant. And if women have periods that are irregular, she could be a week or 2 late, or 3 weeks late, or miss a whole period if that's something that's normal for her, and not realize that she's pregnant. Okay. All right. So I'm just going to go back to the PowerPoint here. All right, so a couple of technologies that are associated with being pregnant, and one of them is an ultrasound. So an ultrasound, they tell you to make sure that you have drank lots and lots of fluid, first of all. And remember, your bladder and baby is right up next to the bladder, so it's really, really hard, but you drink lots of liquid. And then they take images and they look at the images, and they take about 1 million measurements of head diameter and heart and all this stuff. So what they do is they check the age of the baby to see if that matches when the date that you said of your last menstrual period, to determine whether or not you're having a multiple birth pregnancy, looking at the growth and size of baby, to check if there's any defects with baby, and then different complications with the pregnancy. Some complications, it's just about you preparing yourselves for it, for when the baby's born. Some complications can actually be repaired in utero, and we'll talk about that in a minute. So ultrasounds, typically about halfway through the pregnancy is when they're performed. Depends on the pregnancy. My husband and I were using fertility drugs, and so all my pregnancies ended up, I had ultrasounds usually by week 6 to 8, and then several throughout the pregnancy. Okay. All right, so amniocentesis, we talked about this a long time ago when we were looking at non-disjunction disorders. So amniocentesis is a needle is going through the wall of the abdomen. So an ultrasound is happening at the same time, so they can see where the needle is going to make sure that it's not going to hurt the fetus. And remember, all of this is fetal cells, so the amniotic fluid is getting a sample of DNA. Okay, so then we get the fetal DNA. You can put that on a karyotype or use that DNA to diagnose genetic abnormalities. Okay. Chorionic villi sampling. Okay, so again, an ultrasound is done. This is done, we can see the baby looks smaller, or embryo. I guess it's a fetus at this point, but it's quite small. So this is done earlier in the pregnancy. A speculum is used to open up the vagina, so the same device that's used for a pap smear. And then a catheter is pushed through the vagina, through the cervix, into the uterus, and then it's used just to take a little sample here of the chorionic villi, those finger-like projections, because remember, the chorion is just fetal DNA. And again, we have fetal DNA to diagnose chromosomal or genetic abnormalities. So both of these procedures are offered to women that are over 35 years of age. No woman can get forced to have it. I have a friend who had her children later in life, quite a bit later. They offered it to her, and she said it'll be what it is and didn't want to get this done. If you've had a birth defect in or a child with a birth defect that could have been diagnosed with amniocentesis or chorionic villi sampling, or if you have a family history of a genetic or chromosomal disorder. So the differences here to highlight is we can see that chorionic villi sampling can happen a lot earlier in the pregnancy, because if you've decided based on what you've gotten as a result that you are going to abort the child, which is one potential outcome of this, amniocentesis is cutting it really close to the danger zone of being able to do that, where chorionic villi sampling can happen earlier. But if we look, the risk of miscarriage is doubled in amniocentesis. Okay. All right. Another thing to talk about here, and again, we're not going to do, I'm not having you memorize fetal surgery, but just understand that it's pretty cool. Operations can be performed on the fetus while mom's still pregnant, so while still in utero. So these are performed for some cases of spina bifida. So spina bifida is basically where the spinal cord kind of sits out and it doesn't really have the skin that's going around it properly. Sometimes there's a sort of a water cyst over top of it. So when babies are born with spina bifida, and it has different ranges of severity, but I know I worked in after school care before I got my ed degree, and there was a little boy that had to get continual surgeries because he had a stent that was put over top of where that region was in a spinal cord. But of course, as he grew, he needed to get a new stent put in. So this kid at 7 had had multiple surgeries already at his age. So they can also use it to remove a cyst. So there could be a cyst on baby that's maybe going to inhibit some of the development of an organ or other problems. And then the fetus just gets closed right back up inside the uterus. So I was looking at different examples, but I just thought for this video here, it's just a quick little what it is video. Oops.
The whole idea of fetal surgery is that many of these babies have conditions which are life-threatening, and by the time they're born, there's nothing that can be done for them. And the only opportunity that you would have to change the natural history of that condition is to operate before they were born, allow the baby to recover so that by the time they get to the nursery, they're a very different baby.
So it's really cool. And I was looking it up. I don't think they offer this type of surgery at U of A hospital, but they do have it. There's a hospital in Toronto that does offer these types of surgeries. Okay, so if we take a look, so they are opening up the uterus. So we see this developing fetus, and we see this hand that's just come out and hanging onto the finger of a surgeon or one of the assistants in the room. There's a little skinny arm. So it's kind of revolutionary, but of course, any kind of surgery is risky. So this surgery is more at risk because now we have 2 potential lives that we're dealing with, right? All right, next we have an infertility treatment. There we go. An infertility treatment called in vitro fertilization. There's different types of treatments for infertility, but this particular one is one that's specifically pointed out in the program of studies, so we need to know this one for sure. So IVF, in vitro fertilization. So in vitro, that word vitro just means glass. So fertilizing in glass. The very first baby born through in vitro fertilization, and they used to be referred to as test tube babies, even though it's more like petri dish babies, was born in 1977. So that's a long time ago. I was 6 years old. So what happens is eggs are recovered. So in order for this process to work, the woman needs to over-ovulate. She needs a whole bunch of eggs. And so she gets injected with these fertility drugs, okay? So that's what we see with this first one right here. So she needs to super ovulate. So they inject her with a whole bunch of drugs. So there's a hormone that's injected. She super ovulates, so lots and lots of eggs. And then they take a little needle and they aspirate. So they pull out all of these eggs. And then they put some eggs and some sperm after they've taken a sperm sample together in a petri dish. And they try to get as many embryos as possible. So there's a lot of division that's happening here. So divide, 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 divide after fertilization. So you could have quite a few embryos. And then the embryos get implanted inside the endometrium. So This could be eggs from a donor, or this could be mom's eggs, depends on what the situation is of infertility. This could be implanted in mom, or this could be implanted in a surrogate, okay? So the blastocyst gets implanted. So it's not a fertilized egg that gets implanted. It has to be in the blastocyst form. And remember, the woman who's receiving this has to have high enough estrogen and progesterone levels in her body that she has a nice and thick endometrial lining. Otherwise, this won't work. Often more than one embryo is implanted, can be up to 3 or 4, because the idea is that some won't implant, right? And then eventually baby is born. The procedure is quite expensive, and a lot of health plans don't cover it. It's not covered by Alberta Healthcare. The hormone injection itself, I believe, just a couple that are friends of ours, $3,000. That was part one. And then every time, so that's part one is that, and then the aspirating of the eggs and everything. So that's all included in that $3,000. And then every month, when we try to do the implantation process, was another $5,000. So I think their pregnancy took on month 3. So that was $18,000. So yeah, so we'll just watch this little video here. Actually, I think we will leave it, and we'll watch that next class, and then I'll talk a little bit more about that as we get into pregnancy. So next class, we're going to talk about, childbirth. So we're going to talk about parturition and lactation. And those are our last 2 things to talk about. And then we're done the course. So yay. So the worksheet that I gave you today, you can start working on it. We haven't done parturition or lactation, so you can hold that off, but the rest of it you can do. It is due Sunday at midnight, but the sooner you can get it to me, I can start marking them and then get them back to you. Any questions? All right, so you guys have a great day then, or a great rest of your day, and we will see you on Friday. Friday will be our last formal lecture. So we are almost at the finish line, guys. Have a wonderful, wonderful day.